Okay, this is part two of the gait training video. I think we about finished this slide, but in general, we're obviously, as we're going to that third bullet point, stability, we're wanting to err on the side of too much stability if we're going to err, and we want to, and we can always upgrade the assistive device to less stability as the patient progresses. And of course, there may be considerations as far as what's available for their insurance to pay for and what space they have to store a certain assistive device and so forth. So this is a progression showing the most stable assistive devices down to on the bottom right, no device at all. So the parallel bars, uh, which here's a picture of those. The parallel bars are the most stable situation. Then we go from a walker, which has 4 points of contact with the ground, to bilateral axillary crutches, bilateral forearm or Lofstrand crutches, and then bilateral canes, which is very seldom used. A hemi walker, a quad cane, single point cane. So we'll go through each of these now and discuss. These parallel bars are available in most rehab gyms. Uh, so if your facility where you're working or doing a rotation has them, as we discussed earlier, it's a great opportunity for pre-gait type training uh, and so forth. It has standard walker, which can fold, and also, of course, the height can be adjusted. A front-wheeled walker. Now, a platform is something that can be added to not only a walker, but also even to axillary crutches. And in lab, we will demonstrate how to do this. There are 2 points of attachment to, in this case, the walker, and then there's the platform that the patient's upper extremity will attach to. You see a Velcro strap to strap their arm in, and that handle can be adjusted for the how far out it extends and also if it needs to be rotated to fit the patient's grip. So this would be a situation where a patient, for example, has suffered a wrist fracture and are non-weight bearing on their upper extremity. This is a way that you can take the wrist out of the equation, and so now they'd be weight bearing through the forearm and uh, rest of the upper extremity. So this is the uh, type of attachment that can be very problematic in practical exams. So this is something you want to make sure that you have worked with and feel comfortable with, so that if you get a case on your practical exam that is non-weight bearing on the upper extremity and this device is indicated, you want to make sure that you're able to navigate this successfully. This is a four-wheeled walker, sometimes called a rollator, with hand brakes and a little basket. Also, you can lock the brakes and the patient can turn and sit on the walker if they need a break. So this is for a higher level patient and for more long-term use. But these all four wheels swivel, and so this provides a lot of mobility for patients. This would not be indicated for a patient who is not able to use the brakes effectively and who doesn't have enough balance to walk more quickly with the four-wheeled walker. An example of a pediatric walker, just like our wheelchair lecture, there are many customizable uh, types of walkers for patients, and there's very specific needs. So if you're working in a pediatric type setting, this may be something that would be used. There's also another example of a pediatric walker that has the front open, and for some patients that is more helpful. Axillary crutches. There's, as we said, that platform can be added not only to a walker but to a crutch. These are Lofstrand or forearm or Canadian crutches that can be used for some patients. Here is a hemi walker. So this, as you see, has 4 points of contact on the ground, similar to a front-wheeled or a pickup walker, but it is used just with one hand. So it's called a hemi walker because often it's used with patients after strokes or head injuries and they have hemiplegia. So it provides more stability for the patient who can only use a one-handed assistive device. So there are two kinds of quad canes, a wide base or large base, or a small or narrow base quad cane. We will look at these in lab, but So this stands by itself, which is helpful. Single point canes have to be leaned or up against something or hanging, whereas a quad cane can stand on its own next to the patient. And then obviously the two different sizes provide more or less of a larger base of support. Single point cane or standard cane, all kinds of different varieties and handles. They're also adjustable. Um, some grips are molded to shape the hand of the patient. So in general, as we're fitting assistive devices, the basic considerations are the height of the assistive device, and so we want to have the end result be 20 to 25 degrees of elbow flexion. In the parallel bars, we want the bars to be wide enough that there's at least 2 inches of clearance on each side of the patient's hips. Uh, when we're looking at a cane or a walker or a crutch, we want the height of the device to basically come to the greater trochanter or the ulnar styloid process with that elbow flexion, which we will review all of this in lab on Monday. For axillary crutches, we want to have that space between, there are, I guess, two measurement considerations. One is the overall height of the crutch, and we want to have 2 or 3 finger spaces between the top of the crutch and the axillary region to avoid putting pressure on the brachial plexus. And then the other measurement is the hand grip, and we want to have that 20 to 30 degrees of elbow flexion. So we want to instruct patients with axillary crutches that they do not weight bear on that top axillary pad because of the potential damage to the brachial plexus. All of the weight bearing happens at the hand grip. And so we'll talk about ways to fit the axillary crutches to your patients. So if you want to be mathematical, you can do this and calculate 77% of the patient's height. Most therapists don't do it this way. They will just focus on the elbow flexion and the 2 to 3 finger space in the axillary region. For one very helpful method for fitting crutches or a walker when your patient is supine in bed is you can take the crutch or the walker and hold it up next to the bed and have basically a general idea of the height of the walker or the handles on the crutches to come to the greater trochanter. Then once your patient stands up, if you need to make more minor adjustments, you can do that. Again, we'll show you this in lab on Monday. So another way, if your patient is sitting and not supine, you can do this asymmetrical tonic neck reflex position where one arm is extended out to the side and the other arm is flexed like you're ready to shoot a bow and arrow, and then you can measure the axillary crutch from the tip of the elbow to the outstretched hand. We will show you this in lab on Monday. So, different types of gait patterns. First and foremost, reciprocal gait, normal gait. If you need this review, basically one upper extremity and the contralateral lower extremity advance together. So when we're walking, we advance our right foot and our left hand, and then we take our next step with our left foot and our right hand coming forward, and that is basically 2-point gait. There are 2 points of contact with the ground, meaning our 2 feet as we are ambulating. So this is a 2-point gait pattern. And if an assistive device is being used, the assistive device is in, for example, the right hand. And so when the assistive device and the left foot advance together, and then we take a step with the other foot. So these gait patterns are very difficult to describe just with words. And when we are able to demonstrate them in lab, this will be very clear. And then there are 2 different kinds of 3-point gait pattern, and basically it has to do with non-weight bearing or partial weight bearing. So this gait pattern, imagine somebody walking and not able to put one foot down on the ground, and they're using crutches. So they would basically advance the crutches and then hop forward. So that basically the reason it's called a 3-point gait pattern, there's one crutch, two crutch, and 1 foot. So those are the 3 points of contact with the ground. And we'll talk in a few minutes about a step two versus a step through gait pattern. Then with partial weight bearing, it's the same idea. Basically, the crutches advance, and then you're able to kind of walk through with your partial weight bearing limb, and we'll demonstrate this in lab. A 4-point gait pattern can be very difficult. It takes a lot of coordination, but you're basically doing your arms and legs in 4 different steps. So if you can follow the little picture here, you've got a crutch in each hand. You step forward with the right foot, and then you bring the left crutch forward. Then you step forward with the left foot. Then you bring the right crutch forward. So for some patients, this is helpful to, if they're having difficulty getting the coordination of the walking pattern with the crutches, this is perhaps a beginning stage to help them get that figured out. So swing two to swing through. This is a typical progression for patients when we are teaching them how to use crutches or a walker. Swing two means they'll advance the crutches and then hop or swing just up to the level of the crutches, and then put the crutches forward again, and then hop up to the level of crutches. Once they get the hang of that and they're going faster, then they'll advance the crutches and then swing past the crutches, putting that 1 foot down, advance the crutches again, swing past the crutches, putting that foot down. Once again, once you see this in lab, it'll all make much more sense. Now, if your patient begins to fall, obviously this is something we want to avoid. However, accidents do happen and the unexpected does happen. And so, again, the reason why we never leave a patient who's not independent in ambulation or just standing, and especially on a practical exam, because the assumption there is this is a patient who is new to the therapist. And so because human instinct is to, if let's say you're next to your patient helping them ambulate and suddenly one of the axillary crutches slips out, or they start to become dizzy, if for whatever reason they start to lose their balance, our instinct is to reach out and grab for them, and we can harm them or ourselves. So we want to have that proper grip on the gait belt at all times. That prepares us. And at times we can pull the patient closer to us, support them with our body. If they have to go down, sometimes we need to just lower them using our leg, kind of slide them down our leg to the ground, just to try to decrease the speed of the fall, everything we can to try and protect the patient. So we'll kind of practice this in lab. And in your textbook, in this gait chapter, there are some discussions of do's and don'ts with ambulation. And so they talk a little bit about when a patient's falling. So this concludes our gait training and assistive devices presentation. This was just to give you a little bit of a foundation and general preparation before lab on Monday. We will see you then. Thanks.